Welcome back to The Explainer. Today, we're going to transform some incredibly high-stakes pediatric clinical data into a clear, visual audit of life or death decisions. We're taking a highly structured, analytical look at some of the absolute most critical physiological divides in neonatal and pediatric medicine.
We're talking about those absolutely terrifying 50-50 clinical dilemmas. You've got two conditions that look superficially identical at first glance, but they actually demand entirely opposite split-second interventions. The margin of error here is basically zero.
All right, here is our roadmap for today's explainer. Number 1, the neonatal 50-50 dilemma. 2, cyanotic kinetics. 3, the GI emesis timeline. 4, fatal errors to avoid. And finally, number 5, the point of no return. Let's get right into it.
Starting off with Section 1, the neonatal 50-50 dilemma. Picture this. You've got a clinical lawyer demanding an EKG for a blue baby to figure out a structural plumbing error, and they need answers fast. You are essentially looking at a right-to-left shunt. On the left side of your screen, transposition of the great arteries, or TGA, creates two parallel circuits. The aorta and the pulmonary artery are literally swapped. The oxygenated blood just circles right back to the lungs. It's totally incompatible with life unless there's a shunt. Now on the right, tetralogy of Fallot features a ventricular septal defect, and the degree of obstruction in the right ventricle is what dictates exactly how much blood is forced out to the body. Moving right along to Section 2, cyanotic kinetics, the divide.
So, the absolute crucial tipping point here? It's pulmonary blood flow. TGA floods the lungs with increased markings, while TOF totally starves them. Because TGA features those parallel circuits we just talked about, cyanosis is profound, and it happens immediately at birth. TOF, however, relies heavily on systemic vascular resistance. That means cyanosis might actually be entirely absent at birth, developing over months and presenting as those classic, terrifying TET spells when the systemic resistance drops.
When you're running a strict clinical audit, you have to aggressively filter out the noise. A single S2 heart sound, well, that's just noise, because it happens in both conditions. But a child instinctively squatting during a cyanotic spell, now that is a massive signal. Squatting mechanically increases that systemic vascular resistance, which naturally pushes more blood right back through the VSD into the pulmonary circulation to finally get oxygenated. On the flip side, if you have a newborn who is immediately blue and throwing 100% oxygen at them does absolutely nothing to improve their oxygen levels, that is your screaming signal for TGA.
Okay, pay super close attention here, because this is exactly where catastrophic dumb mistakes happen. If you have a suspected ductal-dependent neonate, administering high-flow 100% oxygen is a deadly trap. Why? Because oxygen is a highly potent pulmonary vasodilator that can rapidly close the patent ductus arteriosus, leading to total circulatory collapse. If a baby has TGA, that little PDA is literally the only thing keeping them alive by letting just enough oxygenated blood cross over. You absolutely must maintain that opening with intravenous prostaglandin E1 until the surgeons can step in. Giving oxygen in this scenario isn't just unhelpful, it's like slamming the only escape door completely shut.
All right, on to Section 3, GI obstruction and the emesis timeline.
When a baby presents with vomiting, the clock is literally your best diagnostic tool. The tipping point of age completely shifts your differential diagnosis. We go from an early mechanical hypertrophy in, say, a 1-month-old, all the way to a telescaping of the bowel in a 10-month-old. Time is everything.
We're basically shifting our diagnostic dividing line based on the ampulla of water. Because the pyloric blockage sits above the bile ducts, the baby shoots out milk looking exactly like it went in. It's forceful but entirely non-bilious, and it leaves a very palpable olive-shaped mass. But intussusception, that happens lower down. It causes sudden paroxysmal pain, bilous vomiting, and a much larger, sausage-shaped mass, accompanied by those classic currant jelly stools.
Check out this severity invasiveness matrix. It perfectly organizes our immediate next steps, proving that surgical repair is entirely dictated by the patient's systemic stability. Got a stable 4-week-old with pyloric stenosis? You don't rush to the OR. But a 10-month-old with suspected intussusception and signs of shock? You completely bypass the diagnostic enema and go straight to emergency surgical exploration. If they're emergent but stable, an air or contrast enema can actually serve as both diagnosis and treatment, frequently popping that telescoped bowel right back into place.
Let's look at Section 4, fatal errors to avoid. So here's a massive trap that catches way too many people off guard.
rushing a baby with pyloric stenosis straight to the OR. The mechanical blockage itself is not the true emergency here. The metabolic derangement is. They've been violently vomiting hydrochloric acid, leaving them with hypochloremic metabolic alkalosis. If you put them under general anesthesia before fixing their blood chemistry, they are at an insanely high risk for postoperative apnea. You absolutely must hydrate first, correct those electrolytes, and only then schedule a pyloromyotomy.
And finally, Section 5, the point of no return.
This is a huge executional pearl right here. If a kid with a known large ventricular septal defect suddenly presents with new onset cyanosis and clubbing, well, the window of opportunity for surgical closure has slammed definitively shut. Here's what happens. Initially, a VSD pushes blood from the high-pressure left heart to the lower-pressure right heart. It doesn't cause cyanosis, but it constantly bombards the delicate lungs with excess blood volume. Over the years, the pulmonary vessels scar and harden just to protect themselves. Eventually, the pressure in the lungs becomes higher than the systemic pressure, and boom, the shunt violently reverses. Now, deoxygenated blood is being actively pushed out to the body. Welcome to Eisenmenger syndrome.
Understanding this physiological flow is just absolutely paramount. Attempting a standard surgical fix at this late stage? That's a fatal error. Think about it. The right ventricle has spent years pumping against the low-pressure escape hatch. If you suddenly close that hole when pulmonary pressures are irreversibly high, the right ventricle will immediately fail. The standard correction is permanently off the table, and your only real execution left is medical management and getting them evaluated for a longer heart-lung transplant.
Whether it's intentionally withholding oxygen to keep a PDA wide open or strictly correcting electrolytes before you even think about a pyloromyotomy, excellent clinical execution means always respecting that physiological timeline. So once the hemodynamics violently reverse to Eisenmenger syndrome, are we actually still treating the heart or just managing the fallout? Keep aggressively auditing the signals, always ignore the noise, and we'll catch you on the next explainer.